And as you're joining, go ahead and put your name, your hospital, and your role in the chat. We love Vermont because we know most of you, but we're hoping there's some new folks with us today. Refresher for some and new for others. So tell us who you are and where you're from. And you don't have to tell us what you're eating for lunch. I made a poor choice, as I often do. Leftover tortellini, which I don't really remember eating because I ate it too quickly because I was getting ready for you all. Welcome, 12:03. As I'm going to give people till 12:05, but I'm going to continue to narrate as I like to do. So, joining us today on the health department and VCHIP side, we have Cindy Hooley, who you all know. Well, if you're new, you don't. Cindy is all things health statistics, vital records, a great source of information for you. Katie Leffel's here. She's our perinatal nurse, everything. We have Angela Zinno from the VCHIP team, who is going to win every award for communication skills. So if you need anything, Angela's always available. Courtney Devlin, a great addition to our team a while back, data manager. You're stuck with me today as a perinatal quality collaborative Vermont faculty. I'm a pediatrician by training, but I love OB. And Julie Parent, she's our project director for Perinatal Quality Collaborative Vermont. All right, we've got everybody introducing. Yeah, Kathy's from Springfield. That's a cool abbreviation of Springfield. SPFLD. Okay, well, welcome. As we like to say, if you're intending to be part of a birth certificate quality improvement best practice refresher training, you're in the right place. And if you've joined in the last minute, please, I'll continue to remind folks to put your name and your hospital and your role in the chat. Next slide. Okay. So why does this matter? We are so grateful for the attention that all of you put toward this data collection for Vermont's birth certificates. And the intention of this slide, besides to be so fun and black and white and archaic, is to remind ourselves we have come so far in how we collect data and understanding the impact of the hard work to get the data into the system so that physicians, public health officials, policymakers, leaders can look together at what's working and not in the space of perinatal quality. And I really, really, really want you to know how much this matters to everyone that you work this hard to get the data right. And we have so many examples of when we notice something that's drifting or that we're not attending to as a great state, and then we're able to see accurate data and do quality improvement to fix it because we all have the same North Star, which is better outcomes for pregnant people and children in the state of Vermont. Next slide. Okay, we love a good housekeeping. This is an interactive call. And I know that's hard at lunch, and I know that's hard when you're off camera, but we are going to talk at the beginning about all the stuff, and then we're going to open it up to you. If you're comfortable coming off camera, great, but the chat works great for us. We are very chat responsive and we know you know how to use that. If you want to speak, we will look to see who's unmuting or be attentive to that. And then please know if you need the captions, there is a navigation bar for that. And we're going to finish a few minutes early so that we have time at the end. The Vermont Child Health Improvement Program is all about quality improvement of ourselves as well as the perinatal world. So please stay on and tell us what worked and didn't work about this call in a very brief evaluation. Next slide. Okay, we were welcoming. We're going to look over the project that just the last year and a half or year and some change that you've been helping us with, the Birth Certificate Quality Improvement Initiative. We are going to remind everyone of the incredible education opportunities and learning resources available in this space for ongoing learning. This team is also always available to you. And then we're going to look at the actual variables that we dove into, and we learned a lot this year that we want to make sure you know. And then we'll have plenty of time for questions. Next slide. My new way to say Q&A, by the way, is we'll have plenty of time for questions and maybe not have any answers. But that's not really true of birth certificate quality. That's true of this earth, this current world we're living in. Okay, we are very proud of this slide and we love a good timeline slide. So just if for those that are new or came on in the middle or wonder what on earth are we doing, this is the catalyst for this energy between the health department and VCHIP was a CDC grant in perinatal quality. And we were able to very quickly realize from all of your hard work which variables make sense, which do not, where some of the gaps were in what it's like to be a health information manager and a person who enters data, and a clinical team that also looks at the data in various ways. And so we kicked this off together in June of 24. We've had lots of learning sessions with you, which have generated products and work for us that to make things clearer. The specific examples of that are and we'll show you this later, we created a tip sheet on how to do this work. We also included an insurance tip sheet, and we've done a lot on our website to create ongoing tools for you in this pursuit. So we wanted to make sure you knew about our website. It's on the VCHIP page, and it's actually under Birth Certificate Quality Improvement Initiative. And here we are in October of 2025. And then we're going to look one more time at your data in December, those that are participating. Next slide. Okay, we believe so deeply in what you do that we need to show this slide all the time. Many of you know I was a pediatrician at Porter Hospital, so I was on the other end. I was in your seat, understood very much that data was being asked of us. It took me a long time to realize how important the data was. So I'm actually an authentic community human, and we're grateful for your work. We also can't put this slide up without acknowledging it is a very stressful, hard time to be in a community setting in the care of pregnant people. There is a fair amount of energy around healthcare reform and what to do about birth and birthing hospitals. We remain in full support of your efforts. We know that what you do is safe. And we do want to make sure you all know there is a data brief that we put together with a lot of collaborators to describe the current state of birthing in Vermont and what closure of birthing hospitals would mean for our world. So we'll put that in the chat as well. Thank you for being here. Next slide. Okay, I think I'm turning it over to Katie Leffel, who I
Yeah.
already introduced, but you can introduce yourself as well to do some reminders.
Okay. Yeah, I'm Katie Leffel. I work in the Family and Child Health Division at the Department of Health, and I am a liaison with the Perinatal Quality Collaborative. So I've been working with the team on this project. And I'm just going to share a couple of the educational resources that were developed for you all. So kind of next slide, please. First of all, foremost importance is this is the Vital Records Office phone number. They're your biggest supports if you have questions. Always reach out to them and ask them questions. They're very helpful and have been essential for this project, which is not a surprise. All right, next slide, please. So this first one is a guide that is put out by the federal government, the CDC, around the filling out the birth certificate information, so definitions, instructions, keywords. You can get a hard copy if you want. It's also online, available online. And so we put here the link to the worksheet itself or the guide itself, and then also who to email if you actually want a hard copy. And that was updated fairly recently. So that's like most complete guide. Next slide, please. So this is another training, which is, so the other thing is a guide you can reference throughout time, but this is like a training that you can take. It's free, it's on the website. You can get some continuing education credits if you want. And anybody who is entering data on that birth certificate at your hospital would be really important to take this training. So clinical teams, as well as the health management information teams as well. And like I said, it's free and it's virtual. And I see that I'm supposed to also do some jargon busting. So the NCHS is the National Center for Health Statistics, and EBRS is the Electronic Birth Registration System, for all of you who don't know what those acronyms mean. All right, next slide, please. So these are some Vermont specific resources. So the first two are national resources, and then these are Vermont ones that created. It's a hospital tip sheet. So this was co-created as part of the project with the hospital teams and the vital statistics team and the PQC team. So it's got a lot of very detailed information, and you can also update it and edit it on your own team. So you can make this specific to your hospital. And it's on VCHIP's website, and you see the link there. And this is a really great resource to go question through question of where typical, where some of the problems have risen that we've seen with teams. And so that's a Vermont specific resource. Next slide. This is our Vermont insurance tip sheet, because that was another place we saw some inconsistencies when we were reviewing all the data. Was around types of insurance and how to know if it's private or Medicaid or other. So we went through and we listed and we updated the vital statistics team, reviewed it for accuracy and everything as well. So this is the updated version of all the insurances and how to code them. Also on the website, there's a link here, and I'm sure these slides will be sent out afterwards. Oh, you're putting them in the chat as well. Oh, no, that's a different, sorry. Sorry, I'm looking at the chat and at the slides. All right, I think I'm going to hand it over to Courtney next, but these are just some of the resources for you guys available.
Hi, everyone. For those of you who don't know me, I'm Courtney Devlin. I'm the data manager here at the PQC, and I'm just going to touch on some of our findings from the baseline chart review that we conducted last year to see how the Vermont birthing hospitals were doing with the accuracy of the birth certificate information prior to this birth certificate quality improvement project kicking off. So what we did was we looked at births occurring from July 2023 to December 2023 in 8 participating hospitals in their medical records. And then we compared the occurrence of the 11 indicators on the right side of the screen here in the patient charts to what was recorded in the birth certificate data for the same time frame. And that birth certificate data was shared in an extract to the PQC from VDH. So our findings are within the bar graph here on the left side of the screen. You can see that the payer indicator was the most frequently out of agreement, so had greater than 5% difference between the patient charts and the birth certificate data, meaning that what was recorded in the chart for the labor log, that insurance type, didn't match up with what was recorded in EBRS, the birth certificate registration system. So if you were paying attention to what Katie said, hopefully having a Vermont specific worksheet talking about these are our available insurance plans, these are the types, that will help. So this is a QI project, and the resources that we created for you are really reflective of the findings in the baseline chart review. So after insurance type, we have 5 hospitals had a difference of greater than 5% between the charts and birth certificate data for assisted ventilation required immediately after delivery. And that is an indicator that we will be defining later on in the call because it has a very specific definition. And then there were also 3 hospitals that had greater than 5% difference for NICU admission and gestational hypertension. And you can see the other frequencies of the indicators here in the bar graph. If you're new to the project, you might be wondering why these indicators, right? Why were they chosen? So we worked with a group of clinicians that have a lot of experience reviewing perinatal data. Each hospital has a statistics conference annually with the PQC where all of the numbers are reviewed painstakingly because the clinical team members that are here know it's really the outcomes are crucial to so many aspects of the care of the patients and also the hospital in general. So these are the 11 indicators that were chosen to represent the accuracy of all of the birth certificate data at large. Next slide. So this is just a different way of showing the findings of the baseline chart review. You can see these are the top 5 indicators among hospitals with greater than 5% difference. But here we've broken out the payer indicators. So the most common discrepancy was among private insurance plans being miscategorized, followed by Medicaid insurance plans being miscategorized. Then you can see gestational hypertension, assisted ventilation required immediately after delivery, and NICU admission. And if you have any questions about these findings, you can just pop them in the chat, and after my portion here, I will answer them. Next slide. Okay, so the great news is that now we want to see how the data quality has improved. So we are starting with a follow-up chart review. It has just kicked off in the past 2 weeks. So we are going to be doing an internal chart review for this chart review. That means a member of your hospital team involved in the birth certificate process, whether that's charting, chart abstraction, or data entry into EBRS, will be doing the chart review and then send the data in Excel and REDCap back to us, and we'll analyze it. And then we will be doing individual data review meetings with each hospital team in the winter. And the plan is also to have a larger data summary call sometime in December as well. So we have, like I said, already kicked this off, but there are some hospital teams that we're meeting this week to go over the process. So if your team is interested on the call and hasn't contacted me, please be in touch because we definitely have really a lot of interest in seeing how all the hospitals in the state are doing. And for the data review meetings early next year, please include as many people as possible in the birth certificate process in the call. So any new members of the team, any clinical folks that weren't involved previously, anyone who's new to health information, any of that. We love to see as many faces. You don't even have to come off camera. We just really like to get the message spread on how to improve the quality of the data. Next slide. And I think I'm passing it back to Brina.
Thanks, Courtney. Hi, everyone, again. Hey, if you're not shy about this, we would love to know if any of you, if this is your first rodeo. If this is your first, if you've been recently hired or you weren't part of these teams before, that would be of great interest to us. But maybe we've all done this together already, and this is more of the refresher. Okay, my job is to go through these variables. We've had some fun with this year. I want to make sure everyone knows sometimes the clinical definition of something isn't exactly the way the birth certificate has standardized its collection. And the reason that's important is clinical practice changes and improves and gets more clarity. and it's a little bit of a slower movement to change the exact definitions of birth certificate indicators, which is okay. It's taken me a long time to accept this, but the reason it's okay is because the birth certificate indicators are standardized across all the states, which produces really good data for us to understand the experience across the country. And so we can't just be flipping around and changing every little thing. There will be a journey soon. Cindy promises me someday soon. Some of these indicators will be updated, but not that soon. Next slide. Okay. These are the ones that we've identified over the last year and a half that create a little bit of discrepancy. Not terrible, but a little bit. And there is an overarching principle here, which we've worked on and we want to keep modeling. Health information managers and clinical teams need to be pals. We'd like you to have coffee together. We would like you to wander about to each other's spaces and to really recognize this is a shared pursuit because some of this data is easy to find for the health information manager, some of it is not. Pre-pregnancy diabetes and gestational diabetes should be pretty straightforward. If there's diabetes present in a person, did it exist before the pregnancy? And if it did, it's not gestational. So that's pretty straightforward, but it's hard because you can't check both. So you really have to drill down on when the onset of this diabetic situation occurred. And this requires sometimes an understanding of the primary care of the person before pregnancy. And what we've unroofed this year is maybe the communication between a primary care medical home and a community isn't that clear to the obstetrical provider. So maybe it's a problem of wishing that we knew better some of the pre-pregnancy diagnoses in our patients. Next slide. And you are welcome to throw questions in real time because each one of these slides has its own indicator. So the same exists for pre-pregnancy hypertension, gestational hypertension. Although it's possible to have chronic hypertension with superimposed preeclampsia, our primary intent is whether the condition began before or during pregnancy. We're trying to establish that line of the presence of hypertension before pregnancy. Please do not check both. Next slide. Okay, so we've had so much fun with our clinical teams. Big shout out to the maternal and fetal medicine docs and also Cindy's colleagues in the CDC. The presence of pre-existing or gestational diabetes should be part of an admission history and physical. So we're actually using this project to keep best practice going. So if it's not, and you're wondering as a HIM person, we need you to talk to the OB provider because the unclearness leads to inaccuracy, right? Because we don't know exactly what we're checking. Clinicians will know whether it existed before or occurred during the pregnancy.
Can
Next
I
slide.
ask a question? This is Kathy.
Sure, jump right in.
Well, about that, we're here at Springfield, we do not have a birthing center anymore. And it could be when a mom delivers in the ER, and we don't have access to that information. Sometimes it's really difficult to try to obtain it.
Yeah, well, first of all, we're so glad you're here, Kathy. That is a difficult situation, and your colleagues at Copley Hospital are going to be experiencing this shortly as well. Cindy, any thoughts on that? I mean, my wish would be that there was, so say the patient delivers in the emergency room, emergency department, some attempt at primary care, like the record from the primary care office could be electronically available in the ED. So it could be somewhere in the EHR upon admission. But if it's not occurring, Cindy, what should they do? Just don't know?
Well,
Yeah,
yeah, I mean, if it, unless it's known, you really can't check anything but,
yeah,
not applicable or none for that risk factors box.
Right.
If there's a way to get hold of, the actual potentially prenatal care provider, that
yeah,
would
Right.
the
be
primary
ideal.
care. Yeah. So Kathy, what we're always seeking in our work is relationships. And so and you're going to have a lot to teach Copley, because you're a few years ahead of this closure. So
Mhm.
if the emergency department doesn't know the pre-hospital entry history of this pregnant person, that's a systems change that we would love to work on. Now, whether you have the bandwidth or, but if that's a recurring note from where you sit, we would like to help with that. Because what that
Yeah,
means is the ED docs have to pay more attention to primary care, and we're doing some work in that space. Does that
right.
resonate?
And it's usually by I come in and mom and babe are already gone and no one knows about what the information is or who the care provider was. And it's just like in and out and it's real, I really struggle. I try sometimes to follow up with the mom wherever she went. And that doesn't always work either. Sometimes I have been successful uh, contacting the mom, like at Dartmouth but we do try.
Oh, Kathy, I have no doubt you try. I think the reason we wanted to have this call, one of the many reasons, is we need this level of interaction and feedback to understand what the ongoing
Right.
challenges are. And
Yeah.
despite putting my brain on this, I actually hadn't thought of that. So that's messy. So all this talk about history and physical and just go talk to the OB falls a little short or a lot
Yeah.
short in hospitals without that. So thank you. We will continue to work for a better world and keep in touch with us because I do think electronic health record, primary care. What it really requires is the emergency room physicians have to attend to that. They
Right.
have to understand that in their role as pseudo OB,
Mm-hmm.
they
Yeah.
have to understand pre-pregnant conditions and its impact on their care, the care of that
Okay. And
patient.
then my last question is, can you clarify, we did have a birth early Monday morning before I came into work at 6. The mom didn't make it into the ER. They were coming up the hill and she delivered in the backseat of the car by herself and then came into the emergency room with the baby. Who's responsible for doing the birth certificate?
Sorry, trying to
Cindy?
unmute myself quick enough. Kathy, certainly we can take this offline,
Okay,
but this is one of those very unique situations with uh, making sure it's completed correctly in the EBRS, because if the
Yep.
mom was she actually on her way to the hospital, or was she out and about and delivered the baby? Because
yeah, on
that's
her
a matter of
way.
whether it's en route or it's just an out of facility birth. But if the baby and the mom ended up at your facility, we've always asked that the hospitals take the lead in completing the birth record.
Okay,
You may not indicate that the birth occurred at Springfield Hospital, but you're completing the record because you're seeing the mom and can certify that the birth occurred.
okay, thank you.
Well, and Kathy, from a quality perspective, we would prefer that as well, right? Because that's what you're doing. Thank you. So this slide says sort of the same thing, and now Kathy's got me thinking, outside the box here, but really recognizing the shared responsibility between a provider and a birth certificate abstractor, HIM person, knowing how hard it is to be a birth certificate abstractor. The providers really, and I don't know if we have any providers on today, but it's really harder than you remember or think to find this information in charts in this busy world. And also on the birth certificate side, figuring out where that history and physical is should give you at least the pre-pregnancy information if it's available. Next slide. Okay. Induction of labor. Initiation of a uterine contraction by medical or surgical means for the purpose of delivering before the spontaneous onset of labor. So this has to be before labor has begun. Examples of methods include things like the artificial rupture of membranes, a balloon, oxytocin, prostaglandin, laminaria, or other cervical ripening agents. So this is not a augmentation. This is not the labor has begun and you have begun, and then you start any of this. Next slide. Again, clinical insight. we should be able to figure out if labor has started in that history and physical when the patient's being admitted and what the plan is in the H&P, history and physical, short H&P. We're doing a lot of jargon busting here. So if it's a good H&P, which it often is, it will say, are we inducing this person or is this an augmentation? And then I like this term uterotonic. You know what that, that would be something that would move along some labor that has already started. And then there should also be note in the history and physical which method, what specific method of induction is occurring. There is a chance it's in the delivery note, and the document should also, it should be in the hospital discharge, the difference between induction and augmentation. So on the birth certificate abstractor side, it's just that comfort with H&P, histories and physicals. And knowing it, unfortunately, you have to look in 3 different places. Next slide. It feels like a good chance to say again, this data matters very much. So this effort to get the data, I promise, is being used for a better world. Okay, breastfeeding. Switching over to the baby for a sec, or for some time. The breastfeeding indicator causes a lot of distress for the clinical teams in community hospitals who are working so hard at the education and support for people to breastfeed. And so this is a good example of something that is the data might not show exactly what the long-term breastfeeding situation is for these particular patients at your great hospital, but for the sake of the birth certificate, you only check yes if the infant was breastfed at any time before being discharged or received breast milk, including donor milk, uh, at any time when they're in the hospital. You have to check no if there was no breastfeeding, even if the person intends to breastfeed. So you can see why this messes with our sense of the world, because uh, people do go home and initiate breastfeed. They have a little trouble in the hospital, so maybe don't breastfeed, and then they might get home and it might mean your rates in a community are better. But for birth certificate, we just want, it has to be a clear line that there was breast milk received, we say, into the mouth or the stomach of this infant before discharge. So I wonder if there are questions. And Courtney, or say anyone, can interrupt if you want to embellish, because these are nuanced. And one other small point, if you get some formula, but you do get breast milk, it's breastfeeding. So it's not, that part doesn't need like a purity. It's not a binary. Next slide, please. Okay, another one near and dear to me as a pediatrician. What does it mean to receive assisted ventilation? Well, our birth certificate data collection people make a distinction. Immediately following delivery or up to several, many hours after delivery, which is different. This indicator is only immediate. So again, hard if you're a health information person. Like, when did this start? So the baby's born and you begin manual breaths at the birth, right away. And this is about bag and mask, or actually the endotracheal tube. This is not blow-by oxygen. And this is not if you have to look down the vocal cords for aspiration or meconium, aspiration of meconium. This is not any kind of bulb suctioning or anything about putting some oxygen in the nose. This is truly the bag or the tube. If for it'd be a pretty rare clinical scenario where you'd go straight into endotracheal tube. There's some very rare reasons to do that. So it's intended to capture newborns at some risk that need, yes, and thank you, Anna. I was getting to that. It is not our friend CPAP, which I think you guys know how funny it is for me that CPAP is continuous pressure airway, but it's also the Child Psychiatry Access Program, which is another one of my things. But maybe you don't know about that as newborn care people or obstetrical people. Manual positive pressure ventilation should be reported if used immediately after delivery. That's what we're getting at here. We really want to know what the risk is to the baby right away. Thank you. Next slide. Yes, there's some good acronyms here, or abbreviations, I guess. This is the airway management list to make sure that you know that you're only looking for bag mask and endotracheal. So if you see an endotracheal intubation, which is the passing of the tube into the trachea, if you see words like oxygen, nasal cannula, again, ask your clinical people, was this actually manual breaths or was this some sort of supplement? Next slide. And there weren't that many discrepancies. I want to be clear on these ones. So you guys are doing a great job. Okay. This one also gets a little confusing if you feel like you have some areas within your hospital for different levels of care, which is pretty rare in Vermont. But this indicator is entirely about whether the infant left your facility to go to another one in the first day. And unfortunately, this doesn't capture if you hang around for a day and then get sick. That's a different indicator, or that's a different project. But this one is trying to figure out if you needed to get to a different level of care and out of your facility in the first 24 hours. Next slide. And again, interrupt. This one also, we figured out through our project what was going on here. There was a little bit of confusion about what's a NICU, because you could think about it as just a little bit of special care or a little more intensive care, but the true definition of a NICU is really just UVM or Dartmouth or Albany. These are tertiary care, they're called, admission in a facility or unit staffed and equipped for the ventilatory support. So that's not what we used to call feeding and growing, and that's not a different level. It's just leaving your facility to go to UVM or Dartmouth or Albany. Or maybe Boston, I don't know if that's happened recently that you would go directly to Boston. So I'll read it again. Include NICU admissions at any time during the infant's hospital stay. So this one's not the 24 hours. This is just, did the baby leave to go to a higher level of care? They do just not include units that don't have the ventilatory support. So if you have a little special care, level 2, if you're familiar with that language, do not check yes. This is leaving for UVM or Dartmouth or Albany. Next slide. Go ahead, Cindy.
Yeah, I just want to add something here for folks on the call who may get inquiries from Vital Records about this. You may have checked like NICU admission and then not included, as Brina said, the infant transfer has a time limit. It's within the 24 hours. So you may have a baby that has gone to a NICU at UVM-MC or Albany Med or whatever, but they were transferred after the 24 hours. So Vital Records will contact you because you've indicated NICU admission, but infant transferred was no. And thank you for your patience as we reach out to you and just confirm that, yes, indeed, we do want to know if a baby was sent off to a NICU unit somewhere. But you're correct if you've not checked the infant transferred if it wasn't within 24 hours. So I just wanted to clarify that. These two questions are kind of related, the NICU admission and the infant transferred, but we've checked with our federal partners at the National Center for Health Statistics, and well, at one point they had said that the fact of an infant going to a NICU admission was the more critical piece of information. So if an infant does go to another facility to a NICU, we do want to see that captured in EBRS. I hope that helped clarify and not confuse.
Well, I think it's a good reminder too that, we're going to need to do continuous quality improvement for a long time because of this complexity. That's all. But Cindy just said a really important thing was that the policy, the sort of state level data, we really like to see was a baby transported, because that gives us the sense of acuity and what's going on with babies, whether it was before or after 24 isn't as utilized from a data sort of meaningful use, but it is still the thing. Where to put it after 24 hours?
I was just going to say, Melissa, assuming you mean like if an infant, just regardless of the NICU, if an infant was transferred to another facility after 24 hours, you don't check that box
Don't
for
check that.
infant transferred.
Yep. So then it becomes all we know is the baby had a NICU, and you would have to do a deeper data analysis to see that it was after the first day. So what we've asked our clinical friends, yeah, how do you let us know? Melissa, thank you for caring about that. That would require that your pediatricians would have their own wonder about that there isn't anyone at the state level that's saying 6% of all babies waited for 29 hours before going to the, do you know what I'm saying? There's no sort of clinical follow-up on that currently. We don't note that. We could do the data analysis though, because we could look at all the babies that went to a NICU from your facility and then look that 6 out of the 7 were in the first day. And then we would know there was one baby that something happened after that first day. But that would need so much clinical integration, right? You would have to figure out from a pediatrician what happened that day because it means that something that was going on and that was stable shifted. And I can make up a clinical scenario for you that I'm sure folks would agree. A baby can develop a infection. So the first day is great, but the second day baby gets sicker. It's so rare, but it does occur. So I don't think we have any place for you to put that second day, Melissa, or third or fourth, hopefully not staying that long, but we do know that your clinical teams could note that if it was of interest in your own quality efforts. Okay, next slide. Okay, I'm going to do Cindy's question before I go in, because payment is where a big chunk of the discrepancies lie. Okay, Cindy's saying, I think the question is where on the birth certificate worksheet facility does it go? There isn't a box to check. Right. We're confirming that is correct. There's no place to say this baby left on the second day. But there is a place to say this baby went to the NICU. And it would be up to the clinical teams to say that was trippy. That was day 3. Do you see what I'm saying? I'd love to do this project though, Courtney, because we could look, and we maybe don't have the capacity, but we could look at of all the babies that went to a NICU in your hospital, which isn't that many, how many left the first day? Because we have that check. We just don't have a second check for second day, third day. Okay, let's talk about payment because we spent a long time here together. So first of all, just to repeat, and there's another slide coming, we updated a list of all the insurers we think hang out in the state of Vermont. It's going to be inaccurate the minute it goes up on the website because there's so much changing in payment and insurers, but it's a good sort of primer guide to just get in the rhythm of there's a lot of people under Medicaid, Blue Cross, but there are lots of others. It's a long list, by the way, which makes your lives hard. We are noticing that we learned so much from communities. Some of you have gone ahead and looked at that tip sheet, like CVMC, and figured out, wait, we know the payers in central Vermont. Let's make sure we get out ahead of this with our billing office and with our health information managers to say, we have a fair amount of patients that come through this hospital on X, Aetna or some other insurer, so that you can start to feel connected to your billing people and figuring out who's paying for the delivery. There is a problem in this data when sometimes there's a payer for the parent, for the mother's care or the pregnant person's care that's different than the payer for the delivery. Maybe Courtney can outline that a little bit for me. If we go to the next slide, wait, I'll go back to that one, Angela, for a sec. I just want to make sure this screenshot is familiar to people. You see where the principal source of payment is under the mother.
Brina,
And by the,
no,
yes, go
sorry.
ahead, Cindy.
I was just going to add something here again. So the issue with this field, it is the principal source of payment for this delivery. It's not, it's for the delivery. The issue that we see is that many times hospitals are checking other, and then in the other payment source box, they are filling in an insurance type that actually qualifies under one of the other categories. So we just
Right.
ask, the tip sheet is to help you identify, typically they are private sources of payment, but they're being checked. You check the other, and then you're typing in, Blue Cross Blue Shield or Aetna or whatever, when actually you should just check off the private insurance category.
Right. Yeah, so I think the next slide gets at that a little bit. And I hope people understand this data matters a lot. A lot of this, all the data matters, but this indicator is such an important quality observation about the experience of being a Vermonter because we can't allow discrepancies in outcomes depending on whether you're able, what insurer is covered. It's a really important from a public health perspective. Okay, next slide. Let's talk about this a little more detailed. So as Cindy just said, you check the source of payment for the delivery. That's your job. And it's all confusing because there's a newborn, there's a pregnant person. Oh, what I wanted to say on that last slide, especially because Katie Leffel is off camera, I mean on camera, the word mother appears all throughout the national data collection tools, and that is not our Vermont approach. We work very hard on gender inclusive language, and we do not use the term maternal or mother. However, as I said earlier, things don't change very rapidly in the national world and the CDC, and it certainly isn't going to change anytime soon based on our current climate of how we use language in this country. So I just really needed, we continue to want your feedback on words in this collection that don't feel equitable or right to you, because we hold that for the world that we wish we were in. So please be in touch. Okay, next slide. So if you're unsure what a source of payment is, because this is so much discrepancy in our chart reviews, we would love for you to find your billing people. And I told you I worked at Porter Hospital, and I don't know where the billing people were when I was there. So I know this might be a treasure hunt or a scavenger hunt to go find your billers. They could be off-site as well, which I find quite awkward, but your clinical teams might know, and just really knowing your community with our tip sheet. What do people call their insurance? Is it actually Blue Cross, or is it, tucked in under some other insurer? And then please note what Cindy said. This word other is where we're having the most challenge. And by the way, I check other all the time when I'm doing surveys for things. So I feel the pull toward that word, but there really isn't that much other. Most of our deliveries in Vermont are in this Medicaid or these private insurers, and there are a few in others. So let's work together on this ongoing, and we're learning a lot. So when you tell us what makes sense and doesn't in your community, then we'll know how are we paying for this, because we really should be paying for it. And I like to understand that aspect of our system. The principal source of payment is important. I already said it, I'm going to say it again. I respect and honor that maybe even clinical teams, we think, well, oh, the hypertension variable is paramount. But when you go up that level of how we're going to make a better world, this one really matters. Next slide. They all matter. Okay, there's the tip sheet again. Can you tell we love this thing? We put it in the chat. We put it on 2 slides. We just want you to have a guide because we don't want this to be mysterious, nor should it. Next slide. There, we did it. It's 12:51. I think we can take the slides down. so that we can really talk together. I appreciate the chat, real time, that you're already wondering. And this is your opportunity to say what's easy and hard and to keep us um, honest about what progress we think we've made this year, but where we still are making more confusion with our verbiage, but also with the sort of discrepancy between clinical teams and maybe national data folks. Anyone brand new to this today? I'm really glad Springfield came, Kathy. That creates a whole, and the fact you had a Monday morning parking lot delivery is exactly our fear of this closure
Yeah,
conversation.
that was a different one. I have never come across that.
Wow. Okay, and Amy, welcome. I feel like we need some sort of prize for you, a fleece vest. I'm on the team. Amy, are you on the health information side or the clinical side?
Yeah, I'm on the health information.
Yep. Hey, Melissa, I noticed that too. Um, and that's an important observation and means there's some effort on our end. Oh, and welcome, Melissa. So just for Amy and Melissa, we've had several of these meetings in the last year plus. The nurse man, there's tons of clinical folks that do come, and their engagement and investment has been terrific. I think what might be happening today, hard to know. It had the word refresher in the invite, and I think the folks on the clinical side might feel like they kind of had the brass tacks. Oh, and Janet's new too. So, we emphasize this really as um, a training, like an orientation for folks who were new and maybe folks that already had heard our long-winded Brina descriptions of these indicators might have opted out. So we can double back with our nurse managers about that. We do have Anna on. I know we have one nurse man. Any other nurse managers on? Does my team been
Jody
monitoring the
is
chat?
here.
Oh, hi, Jody. Julie wanted to note too, don't forget that there's more than just reviewing all the other ones. We're open to hearing about other variables that you're wondering about or that you struggle with when you go to enter the data or you can't find or you don't know what the definition doesn't ring true.
Brina, I just thought of a question with the comment about none of the maternal child department on. I know there are some HIM managers and things, but that raises the question of, for folks who are on the call without some of those other people, since these trainings have been going on, have those folks reached out to you at all? To the folks on the call today? Like, as Brina said earlier on, we're hoping that there are these more conversations between nurse managers and the clinicians and the HIM folks and the folks entering the birth data into the birth registration system, because you'll need to understand, what information needs to be entered into the system.
Such a great question. So Jody's in Rutland and she and her clinical teams are chatting. So for our new folks, which we're really happy you're here, have you heard from any of your clinical team? Have you met them? Are they in a different part of the hospital? Like, what's been your experience so far, Melissa or Janet or Amy? Read the chat. Oh, interesting. Melissa's got travelers. So we are always filling out here in the medical records section. Okay, and someone I'll scroll back up. But Melissa, what hospital you're in?
North Country.
Yeah, I was going to guess North Country. And Amy, good. So you are chatting. I'm letting Melissa do the chatting. Same. Oh, you guys are together. Yay, Janet and Melissa. Well, thank goodness you have a team. There are some sort of relational principles here that matter to me, all of us, especially me as a clinician. Um, we really have worked hard this year, and we have to keep working to make sure that our clinical teams understand how important this is and what you're doing as HIM people is hard. And I wonder, so we want to be a resource team for you if you feel a glitch in that understanding. And, Anna's the nurse managers in general are a great champion for that relational place of, okay, I have a hard job, you have a hard job. We can share in the pursuit of better data. Because I don't really like the idea that people don't feel a team. So the team building around this has been our most important cheerleading, but also we've observed that when that works, the data isn't just discrepant. Is that a word? There isn't that disconnect between a chart review that we would do and what we get sent up to Cindy and her team. So our commitment to you is that if you're an HIM person on this call and there's a little bit of I wish the clinicians were here, then we can work with your nurse manager on, creating that coffee. We're not allowed to have donuts anymore, right? They're not nutritious. Coffee and donuts. Because there is so much quality work going on in community hospitals, and we're trying to over-index to the perinatal side because it's not as recognized by the C-suites, they call it, the CEOs and others are sort of just glad when everything's going well, but they're not the first to say we got to get all these teams together. So we feel that we have a good role in that because the nurse managers kind of they really know the world. That's important to me to say. And it's really hard. I'm so curious at North Country what your geography, like, are you in, so medical records in the same, are you in the hospital? Are you a 5-minute walk to the OB? Are you 25 minutes away? I like geography. 2-minute walk. See, so coffee, you could even walk with your coffee and it wouldn't get cold. So
Unless
the
it's
other part,
February.
unless it's February, yeah, that's true. The other part I love about this, I'll just fill a little more time and then we'll let you get on with your day. I think we had wondered about an hour and a half, but if folks are pondering and contemplating, we've thrown a lot at you. The slides will be coming. The website's incredible. The tip sheet is terrific. But my wonder for you all is uh, where we want you to feel that you can dive into this and see stuff that's hard, and that you can either go to the resources or you can reach out to us to ask the important questions. And there is no space where a question would come forth that wouldn't help us, because everything you're feeding back to us demystifies the world that we're living in of this important data entry. So that matters. And the clinical quality efforts we do are also very important. Having this data be right is going to shore up the obstetrical experience in Vermont. I don't know exactly how to talk about that because I don't have any agency over these decisions about birth hospitals and closure, but I do know that Vermont has better safety data in community hospitals than other parts of the country, so we don't allow policymakers to say, well, it's not safe to deliver in a smaller hospital.
Yeah, we can't make the decisions or help that, but we do get asked, the PQC gets asked for data, and they're in the VDH as well gets asked for this data. So the more reliable the data is, the better it can be used to advocate, for sure.
Awesome. Well, Julie just reminded me we have more we want to say to you, so we're not wrapping up. I fibbed. Melissa wants to know, I don't understand this question, Melissa, you might have to restate. Will they ever put a comment block on the birth system? Does anyone know what that means?
I'm
Okay,
I'm
so
thinking
Melissa, oh, go ahead.
I I'm thinking, Melissa, you're talking about the EBRS and like for weird, maybe like the infant transferred thing that we were talking about or something, a place where you could put a comment about something that's different or
Yes,
hard to
yes.
report. Okay. Um, hard to say. I guess we hadn't really thought about it. It might be something to consider. Unfortunately, our system is built in-house, and at this point, it's about 20 years old. And at one point recently, we thought there were going to be some changes at the national level to the birth certificate. In other words, we don't like to just go in and make one change. We like to have like a number of changes because it does take time to make these changes in our interface and test them and so on. So I guess I could say maybe down the road that's a good
Yeah,
suggestion, and we can keep that in
that's a
mind.
great suggestion. And Melissa, I wanted to make sure what I like, this is a catalyst for conversation at your hospital. I happen to know your pediatricians up there in the North Country. They're terrific, as you know. So if the curiosity was about a baby, the circumstance of a baby being transported after the first day, you could create an internal QI project on that. You could have a little Excel spreadsheet. You could have a piece of paper on the back of the door that checked a box every time that happened, or so sometimes this work is a catalyst for your own hospital to look at something. And then for Amy, way to be new and get right to the heart of it. Yes, we have long known through this project that the smoking box is not representing all the stuff, including vaping. And so holding that, this is exactly what we need from you. There's so much going on that isn't captured in this data. And vaping will get in eventually. It's just that process Cindy just described is not easy. And then Amy also would let, this is so fun. It would be nice for the LMP a comment also, as some patients won't know if they've had an IUD or something along that line. Yes, we have had long conversations about the LMP being unknown or not. Has been no LMP for last menstrual period for folks that are. And so, Cindy, I think we came after talking about this with other groups to the decision you're just going to have to say you don't know. Oh, Amy's saying she got dinged for putting 99999 when you don't know the last menstrual period.
Yeah,
Yes.
and I will say, right, that's part of one of the things I was going to talk about is a little bit the quarterly birth report where if there are a large number of unknowns, we do follow back with the hospitals because we have no way of knowing, was that just missed? Was it just put in as unknown because somebody didn't want to try and find it in a chart? Or so it is difficult because we get dinged by the feds, and so we are instructed to turn around and go back to the hospitals to ask for this information. And the best thing you can do is when we send you those follow-up questions is to indicate, something about IUD or whatever, no menstrual period versus just saying, no correction, unknown. If you can give us a reason, that's what we need.
But you asked us for a, this is Tina from Gifford as well. It asks us to mark the exception box if we're telling you, no, it's not required. I mean, it's a 999, we don't know, and we have to mark that exception box in order to submit that birth certificate. So we still get nailed at the quarter to go through all those reports again. But we've already gone through them.
Oh, you're talking about the soft
For the-
edits when you
In
say
the
the
edits,
exception.
in the edits, it says, Mark, you to submit, you have to hit the exception box for the menstrual, the one we're talking about, and then it dings you again at the quarterly year for the same ones that I marked before, when I'm truly telling you, no, there is no date of menstrual cycle. And I've got the pediatrician, I mean, not pediatricians, but providers asking me that as well, saying, we don't know. We can't tell you because they were on medication. They had a baby between, they had they didn't do or miscarriage, or there's all kinds of different variables, but we're marking that exception box and we're still getting caught. Or I shouldn't say caught, but we're still getting asked to spend an hour to go back through reports again and say, hi, I've looked at this data. I already explained that I wrote no, 9999, and we're still getting the report sent to us to verify it again.
So that's, again, if the general reasons are as you just mentioned, where you kind of, because I happen to know, yes, and recently I think it was Gifford that had a very high percentage of unknowns for the menstrual date of last menses. And my understanding is when the spreadsheet came back, I don't know if there were any comments on it about the reasons for that, but if you could just, don't even go through the worksheet or the spreadsheet, just send back an email and say, the reasons for this large number of unknowns is X, Y, and Z.
Okay.
That way we can go back to the feds and say, this is what the hospital is telling us.
Yeah, because I go digging, and they're like, no, I'm putting. So I have a cheat sheet that I made a cheat sheet of the birth certificate that I enter in for you, and I put this in a packet down on the floor for the providers. They go in and they fill this out, and they're the ones that are marking this all up and verifying that this is, so that's why they're ringing. And I say, you sure? I got 999s all across the board. And they're like, we don't have anything. They don't know. They won't tell us. They won't, it doesn't happen. So I can't give you something that they can't get themselves. And I feel bad because I feel I'm the biggest one to put 9999 in. It's not that I'm not looking, trust me.
Well, Tina, I'm really glad you, we really appreciate, this is familiar. We know this one. I think Cindy's given us some ideas on how to get out ahead of it. And I also want to add something really important. This world we're in hospital quality has a regulatory feeling. You get like dinged and there's all this quality metrics and you guys really have a hard life. This isn't like that. Like when if the feds push back to Cindy and Cindy had, it's meant to be for quality improvement, not to feel like an indictment of anything other than just a silly form. I can put better energy around this to say that, yeah, anything we can do to get out ahead of me. Melissa's saying in the chat, I always write on the form in case I have to go back to the errors, just any little, because think about how IUDs, that again, we haven't updated this darn thing. And since what, Cindy, 2000, and I don't even want to say it out loud. Yeah, it's been a while. So IUDs have transformed our highly effective forms of contraception, but they've also made LMP like a not that interesting part of the journey. And LMP is less interesting than it used to be as technology gets better and better for dating pregnancies, right? So just hold the space with Cindy that it's not our favorite indicator.
I will say in my meetings with the feds, I've participated in a birth, well, it's not a birth change group, I guess, which started a few years ago. And I was always questioning the value of LMP because I know from our
Always.
experience that, so, Yes, the last birth certificate revision was 2003.
I
They
was
used
going to
to
say
do
it
it
out
every
loud,
10,
but I was afraid to.
they used
Some
to
of
do
you
it every
might,
10 years, but
yeah.
yeah. Anyway.
Well, hopefully you were all at least born in '03. Okay, Julie reminded me we want to do a little more cheerleading and send a few more slides your way. So we're going to put them back up if Angela's still with us. I think it's Katie. Thank you for that conversation. Super important.
I
Oh,
think we,
this one's Cindy.
Yep.
I thought
oh,
this was at the end. Yeah.
So I know we're running close to time here. I'm Cindy Hooley, the Vital Statistics Information Manager at the Vermont Department of Health. I recognize a lot of names on the call and would say faces, but no. Anyway, the voluntary acknowledgement of parentage form is not something that's, it's outside the scope of this birth certificate improvement project, but I did want to give a brief overview here and reminder of the process. If you have specific questions about a VAP or VAPs in general, again, please email vitalrecords@vermont.gov. I had put that in the chat earlier. But the process that's been in place now for a few years is the hospital collects the voluntary acknowledgement. Oh, excuse me, I should say the VAP is a voluntary acknowledgement of parentage form, and it is required to add an unmarried second parent to a birth certificate. In other words, at the hospital, if the person giving birth is not married and wants the other parent named on the birth certificate, a VAP needs to be completed. The process is the hospital will collect the VAP from the parents and send it to the Vital Records Office at the Vermont Department of Health, or you can give the VAP to the parents to send to Vital Records directly. It's only if you have a completed VAP that you would check the box in the EBRS, yes, to a VAP, but you do not enter the second parent's information. The reason for that is that Vital Records needs to receive, review, and accept for processing that VAP. So again, you should only check yes for VAP if you know that there is a form in the hospital that's been completed, but do not enter that second parent's information in the EBRS. Please do not apply any stickers or handwritten notes. We've had some VAPs come in that have medical record numbers on them. These are legal documents, and if a parent requests a copy of one for a court proceeding or something, if there's a medical record number in the middle of the form or something, that's tough to make a clean copy. So please do not apply any stickers or write anything on them. When the Vital Records Office receives a VAP, it's typically processed within two business days of receipt. Every form is reviewed. If it's complete, it's accepted for filing, and the Vital Records staff enter the second parent information into the EBRS. If it's not accepted, a letter in the form is sent to the parents typically within 5 business days, letting them know that it's not acceptable for filing and they'll have to fill it in or send in a new form. We do monthly audits to make sure that if a hospital has checked VAP equals yes in EBRS, that we have actually received a VAP form. And then that's when you might hear from John DeMichael or his team in the Vital Records Office contacting you, requesting a VAP that maybe we didn't receive. The reason for all of this is that the Vital Records Office is often contacted by parents who want confirmation that the second parent was added. So we track VAPs that are received and when it's been updated in the EBRS and so on. Ways for hospitals to reduce delays in processing and to reassure parents. If you could make sure the staff who actually enter information in the EBRS are provided with the VAP. I know a lot of the folks on the call here are actually the ones who do the data entry. So hopefully you're getting that VAP from the right folks. Please be sure that the parents have completed all sections of the form and that they have been signed by both parents, and then both signatures actually have to be witnessed. We have received the occasional form where only one signature is witnessed. And unfortunately, that's not acceptable for filing. You can scan an email or fax VAPs to Vital Records as soon as possible and then mail the original later on. Some hospitals hold the VAPs and send in batches once a week. With the ongoing issues with the USPS, that can create some unnecessary delays. So that's why we encourage folks to like fax them or scan them to us as soon as possible. And if you do fax them, please include a cover sheet. Please also give a copy of the completed VAP to the parents and let the parents know that it could take up to 3 weeks from the child's date of birth to have the second parent added. We can't discuss specific VAPs over the phone with parents, and we do get a lot of calls and emails about them because they think it's done like immediately, and that just takes time away from the actual processing. So again, if you could just let them know that it could be up to 3 weeks. Let's see, next slide, please. Do I have time to jump to the, oh, I should ask, were there any questions about the VAPs? I don't want to spend too much time on that because those are questions that I would say are more geared for the Vital Records Office. Okay. Quarterly birth report. So a lot of you on the call, I would think, are probably familiar with this. This is a 2-page report that gets sent out 6 to 8 weeks after the end of each calendar year quarter. It is emailed from our vital statistics analyst, Matthew Mayberger at VDH. And it goes to several individuals at each hospital, including health information managers, nurse managers, hospital leadership in some cases. This is the Q2 2025 report, a sample report for one of the hospitals. Obviously, as it says at the top, it includes births that occurred between April and June of 2025. Page 1 of the report basically highlights timeliness in the bar chart on the right. And under Vermont law, as again, most of you know, births shall be reported within 5 business days of the birth. All facilities on this report are shown, or all facilities are shown so a hospital can see how they compare to other hospitals. And as you can see on this report, all hospitals were above the goal, the 95% goal. So that's excellent. That's what we like to see. The first page also gives a chart summary for the specific facility compared to statewide totals for selected indicators of interest, such as VBACs, adequacy of prenatal care, premature births, which is the gestation less than 37 weeks down near the bottom, and then breastfeeding. Next slide, please. And then page 2 of the report lists selected items that are often entered as unknown in the EBRS. Again, as we've talked about, unknown values limit the usefulness of data, and the CDC's National Center for Health Statistics tracks unknown responses, and they set general tolerance levels. So the items we tend to follow back on are the ones where a hospital is over a certain tolerance level, and that's indicated here in the red, the percentage. That's where you would get, because under our contract with the federal government, we are required to follow up with hospitals when percentages are above the tolerance. Noted in red on the report, in this example, the month of last other pregnancy outcome and all the cigarette smoking are above tolerance. I was going to say, as a side note, on an earlier one of these calls, somebody mentioned that the date of last other pregnancy outcome can be a sensitive item, and we recognize, acknowledge that, understand that. The only I guess one of the things that we suggest is reinforcing to the parent that the information is important for research and could help other moms. You know, the dates of last live birth and last other pregnancy outcome actually permit calculations of intervals, which allow researchers to analyze the relationship of various maternal characteristics and pregnancy outcomes with birth and pregnancy intervals. So for these items in red, a separate list of records with the unknown values is emailed out. Again, comes from Matt, and it's emailed to the hospital staff responsible for entering the information in the EBRS to follow up for the missing information or to provide an explanation for the higher rates of unknowns. So again, as we've talked about, LMP or other variables, if you know, these are definitely unknown and there's a reason for it, if you could indicate in the spreadsheet or in a reply in an email, basically laying out, why there is such a high number of unknowns, that would be helpful and appreciated. We don't get a lot of good response on these follow-up items, and I'm sensing from hearing folks on the call here, you feel like it's sort of redundant and things, and that's why I said if you could write back and just give us reasons for the unknowns, that would be helpful. We've also heard that from HIM staff that quote, the information isn't coming down from the floor, or quote, it's not being entered into the chart or the record, and we can't tell them, meaning the birthing floor or the nurse managers or the women child units, what to do. So as has been highlighted through these trainings, we encourage communication and stress the importance of the communication and collaboration between the clinical staff and the HIM staff to get this information and hopefully get it right the first time. If you have any questions or comments about the content of this report, we usually put on here my name and email address. If you're on the call and you're not a recipient of this report, I will put in Matt's email address in the chat, and you can ask to be added as a recipient for the report for your hospital. And I think that's it. Are there any questions on that? No. Thank you, Angela.
I have a couple more slides to run through just about kind of next steps and things like that. So we can come to the next slide. Thought there was one before this, but maybe I have an old slide deck about what's coming up next. So I will just go here to the slide. So this is just kind of reiterating that it takes a team. So certified nurse midwives, OBs, peds, RNs, LNAs, HIM staff, all come together and to do this. And I want to reiterate Brina's also her comment around, does your leadership know about this work? So do the people, even above some of those in the hierarchy, know that this is happening and the importance of this happening? Next slide, please. So just shout out to the hospital team leads for, some of the pieces around this. For the success was this interdepartmental communication, strong partnering between the clinical providers and the medical health and information record staff, and just also thank you for identifying your clinical leads and your birth certificate health information management leads. That was really helpful. And for the clinical lead roles, communicating with their clinical partners on issues of reporting in the medical records. So kind of what Cindy was just referencing some of her last comments there, and then participating in these virtual calls. And for our birth certificate HIM leads, organizing and encouraging all personnel who work with the birth certificates to also participate in these educational sessions. Next slide, please. So just a shout out to teamwork in these multidisciplinary team approaches to review the records and identify challenges in reporting birth certificate information. So it's been super helpful to learn from all of you, and meeting with some frequency to share the experiences here like we have today. This, again, learning new things every single time we get together. And then just acknowledging all the expertise in the room of all the members of the team, whether they're clinical or health information management, has just been like everybody has so much to share. So next slide. So these are some of the strategies to improve the birth certificate information. So establishing that team approach like we talked about, identifying the best sources of information and specific locations in the records so that it makes it easy for people filling out the information, modifying electronic medical records to capture information consistent with birth certificate items. So that's been really helpful for some spaces. Adopted the use of resources such as some of the guides and definition materials, trained the clinical staff to consistently document information in specific locations in the medical records. Identifying experts in the vital records department for the staff to contact with questions. So, you always need to know your resources. And then training hospital staff on all the new procedures. So making sure that everybody's aware if you've made changes in your hospital around what that looks like. Next slide, please. Oh, I guess we have a few minutes left. I whipped through the slides. In the chat also, Brina shared that the data review meetings will be in the winter of 2025-26 and include all members of teams involved with the birth certificate process. So we're going to have a chart review that's happening right now, and then we're going to meet with the teams to kind of review that data. All right, I had to take a breath. And as any other last minute questions, and I've just loved the engagement today from everybody and hearing all the comments and questions. It's been so great.
Yeah, thanks, Katie. I just wanted to close out by saying sorry that I didn't manage time very well, but it was much more important that we hear from you all. But these last questions are the ongoing to the future questions. We didn't mean to short it here at 128. That what is this like for you? What are your ongoing challenges, which you've shared some today, and what do you and your team need to know or further explore is our commitment to you all as a quality improvement team. So hold that forth. Now you've met those that are new. Welcome. Your job is very important, very fun. And you have a great team behind you. You've got your nurse manager, you've got your clinical teams, when you also have us. So please be in touch. And Angela, I think we'd like to pop up the evaluation with the last minute to give you that space, and maybe we'll send it out after the call as well, so you can tell us what worked and what didn't. There's your red cap survey. Big thanks to the team here. Cindy, thank you so much. Angela, Courtenay, Katie, Julie Parent. And we're grateful for all you're doing. It's not the most straightforward journey, but it's a great pursuit. Thank you. Any other last words from our team? We're glad you joined.